Okay, I'm going to move now to the second story I want to tell you. This is the story about broadening the traditional role of the anticoagulation clinic. Now, many of you, I think, are familiar with anticoagulation clinics, or what for many years were called Coumadin clinics, because they essentially were there to manage warfarin or Coumadin. We realized that it was much better to have a team of nurses or pharmacists manage INRs and then dose changes in warfarin than it was to leave it up to individual physicians to do, because those nurses and pharmacists would follow some set protocols and provide better care. It was also easier for patients to be in touch. Yet these nurses and pharmacists really have a breadth and a depth of expertise in anticoagulation drugs and anticoagulation management that could be used to improve patient care beyond simply adjusting warfarin doses. For instance, they could help assist with drug or dose selection. Should this patient be on warfarin or one of the direct oral anticoagulants, and at what dose? There are lots of things they can do to help minimize bleeding risk. We talked about the periprocedural period. There's also issues with combining anticoagulants and antiplatelets together. And of course, monitoring labs to make sure that there aren't issues with renal function, liver function, and the like. And of course, encouraging medication adherence by checking in with patient is a really important element of what happens in these anticoagulation clinics. I want to tell you a story about this multiple antithrombotic medication issue, because this is one we decided to focus on a few years ago. We know from a lot of data that if you take a single antithrombotic, be it an anticoagulant or an antiplatelet, you have some somewhat similar risk, a little debatable as to whether warfarin and the direct oral anticoagulants are higher bleeding risk than the antiplatelet drugs. But as soon as you start to combine those, that's where the risk of bleeding goes up, especially for patients who are taking 2 and 3 antithrombotic agents, which you see on the lower half of this graph here. And so those are the patients we felt like we could try and identify and do something to reduce their risk of bleeding. Now, interestingly, at the same time, we also had this series of large randomized trials coming out, really calling into question the efficacy of aspirin being used for primary cardiovascular prevention. You know, for so long, I think we as cardiologists in the lay press talked about aspirin, prevent the heart attack, prevent a stroke. Yet with lower rates of smoking, better control of hypertension, and better use of statins, we're seeing that aspirin as a primary prevention agent maybe isn't as beneficial as we once thought. And in some cases, such as in the Aspirin trial, could suggest there's even a bit of harm as compared to placebo. So we decided to look at that in our cohort of patients who were already taking an anticoagulant, meaning warfarin. So these were patients taking warfarin for AFib or venous thromboembolism who we were following for at least 3 months or more. Now, we excluded patients who had a mechanical valve or bioprosthetic valve replacement, or any of those who had a recent MI, sort of the common reasons where aspirin, in addition to an anticoagulant, may be indicated. So then we were left with this group of people for whom we didn't really think there was any strong need for them to be on aspirin while also being on warfarin. And we looked to see whether they were getting aspirin or not. And interestingly, about a third of patients were taking aspirin. And that was pretty consistent over the study period, 2010 all the way through 2016. Really common that this was a case, this inappropriate aspirin use. Now, thankfully, the vast majority of these were using the baby aspirin dose, aspirin 81 milligrams. And of course, we're going to learn a little bit more about 81 versus 325 at the upcoming ACC meeting when the adaptable study is reported. But we said there's clearly a gap. There's an opportunity for us to improve care here. That was especially true because we knew that when you combined warfarin with aspirin, as seen here in the dark blue line, these patients had higher rates of major bleeding on the left and hospitalization for bleeding on the right than the patients who were just on warfarin monotherapy alone. And again, remember, these are the patients for whom we did not have a clear indication for aspirin. So we excluded the valve and the MI patients and all of the like. At the same time, we saw no difference in the thromboembolic events. So no difference in MI rates or stroke or other things like that. So we said, wow, warfarin plus aspirin, harm without any potential benefit, similar to what we had seen in the Bridge study. So we decided to go about reducing this. And in this case, we used a 6 health center collaborative that we're a part of, the Michigan Anticoagulation Quality Improvement Initiative. This is a group that's actually sponsored by Blue Cross Blue Shield of Michigan, our largest funder in the state. And we include academic and non-academic centers with anticoagulation clinics that have both nurses and pharmacists. Some of us are phone-based system, whereas others see patients face-to-face. Some of us are in more integrated healthcare systems, while others are much more traditional health systems. So quite a bit of diversity here. And our goal was to identify the patient who had inappropriate aspirin use, to contact the provider for that patient, whether it's a physician, nurse practitioner, or the like, with some sort of a templated note, and then to help them with aspirin deprescribing if they felt it was appropriate. And what we found is that this aspirin use, while it was slowly declining over the course of time, really fell off once we implemented these processes. So you can see each of the 6 centers implemented this over the course of about 3 to 6 months, and this rapid decline in aspirin use during that time. Now, on the right side of the screen where there's the table, you can also see the adverse outcomes. So bleeding rates dropped significantly. We went from 26 down to 17 rates per 100 person years. The major bleeding rates were also slightly lower, as were the clinically relevant non-major bleeds. And again, thankfully, we saw no difference in the thrombotic rates between the patients before and after the intervention. Now, the question obviously is that's great for warfarin, but most people are now being started on a direct oral anticoagulant. Do we see the same pattern? And there's some data from my colleague, Jordan Schaefer, looking at this that's going to be coming out very soon in JAMA Internal Medicine, showing essentially the same findings. So on the left side of the screen, you can see the bleeding outcomes for DOAC alone in blue, or DOAC plus aspirin in the sort of the yellow, or what we would call maize here at Michigan, right? Showing higher rates of bleeding, both new bleeding and non-major bleeding, and ER visits for bleeding in those patients. While the thrombotic outcomes seem to be pretty similar for most patients in these cohorts. So again, probably the same pattern where you combine any oral anticoagulant with aspirin, you're going to have more bleeding. And if there's not a clear indication, there's probably not a lot of benefit. So our next steps really are to think about, well, how do we sustain this process long term? How do we make sure that the work being done by our anticoagulation clinic continues year over year? And how do we think about expanding that to patients who are on direct oral anticoagulants, patients not traditionally seen in the anticoagulation clinic? And of course, then there's the question, well, what about patients with a history of coronary disease, but maybe that coronary disease episode was more than a year ago, sort of the stable coronary disease patient? Is it reasonable to think about deprescribing aspirin in them? And that's certainly been endorsed by some of the more recent guidelines and expert consensus documents. So could we include those in our processes? And then, of course, what do you do when the clinician says, no, this person really does need to be on an anticoagulant plus an antiplatelet? Is there an opportunity to reduce their bleeding risk through other measures? Maybe putting them on a proton pump inhibitor to try and reduce upper GI bleeding risk. So these are all the things we're thinking about studying and implementing right now.